So now let's say you look on a blood chemistry, and we've talked about how hemoglobin of these first three markers, red blood cell hemoglobin and hematocrit, is really the most critical one in looking at if somebody has the ability to deliver oxygen to the cells of their body. If hemoglobin is low, but perhaps hematocrit and red blood cells are normal, then what you may be looking at is sort of a functional anemia, and not overt type of anemia. But let's consider somebody that has low red blood cell hemoglobin and hematocrit. Now, the MCV, MCH, MCHC, and RDW will help you determine why. But big picture, you really want to decide, first of all, why in this individual may the red blood cell hemoglobin and hematocrit be low. And it's really summarized into these three steps. If somebody has low red blood cell, low hemoglobin, and low hematocrit, the first possibility is there's a production issue. Now, nutritionally speaking, production issues will come from things like iron deficiency, B12 folic acid deficiency, possibly B6 deficiency, or something that's involved with the actual synthesis of hemoglobin and therefore red blood cells. And that may be why they have insufficient amounts of red blood cells, hemoglobin, and hematocrit, is that it's a production issue. Now, more from a pathological point of view, the bone marrow, red bone marrow, produces the red blood cells in response to the hormone made by the kidneys called erythropoietin. So if an individual has significant kidney dysfunction, it may be that they're actually not making enough erythropoietin to actually stimulate red blood cell production in the bone marrow. Now, likely this individual will already know that they have some kind of kidney dysfunction, and if they don't, if you look around elsewhere on a blood chemistry, if things like the creatinine and BUN are elevated, maybe the estimated GFR is low, then what you may be looking at as to why they have low red blood cell hemoglobin and hematocrit has to do with the kidney function. And at that point, really, they should be referred to their doctor for further workup. If it's not a production issue, then perhaps it's a destruction issue. Remember that the red blood cells are said to last about 120 days. That's their normal lifespan. If the red blood cell hemoglobin and hematocrit are all low, and it's not a production issue, perhaps they're being broken down prematurely or too early before that 120-day window. And if that's the case, then the red blood cell hemoglobin and hematocrit might also be low. Things that can cause an increased destruction of the red blood cells include conditions like hemolytic anemia, as well as an anemia of chronic disease. Now, chronic disease is really just essentially chronic inflammation. And when the inflammatory process is going on, remember that the red blood cell, the membrane, is made of phospholipid membrane. Those phospholipid membrane can be oxidized or broken down prematurely, causing destruction. So again, in a moment, we'll look at different ways of identifying if it's production, destruction, what type of destruction, or the third one is possibly loss. Now, in women who are still having their menstrual cycle, it may be that they're losing so much blood during their menstrual cycle that they have low red blood cell hemoglobin and hematocrit on their blood chemistry, that their body does not have enough time to actually improve the production of the red blood cells to make up for or compensate for the amount of blood loss they have. So if a woman is still in her menstrual cycle or still menstruating and has low red blood cell hemoglobin and hematocrit, I honestly think it's a fair question to ask, how heavy are your cycles? And if it's a really, really heavy cycle, then that may be what you're actually looking at in terms of not having adequate amounts of red blood cells, hemoglobin, and hematocrit. Now, loss can also occur from excess bleeding in other individuals, like in men or menopausal women who no longer have their menstrual cycle. And if a male or a menopausal woman has low red blood cells, hemoglobin, and hematocrit, it has to be considered that if it's not production or destruction, that maybe it's loss. And the largest area of loss in either men or menopausal women is some kind of gastrointestinal bleed. Now, this could be anything from a bleeding ulcer, for example, or polyps found in the large intestine, or even something like colon cancer. But in any case, if a man or a menopausal woman has a low red blood cell hemoglobin and hematocrit, and it doesn't appear to be a production or destruction issue, they should likely be referred out to their doctor for a further workup just to make sure that it's not a blood loss issue from some kind of gastrointestinal bleed. So now in the next section, let's take a little bit closer look at these particular three steps and how we can actually identify the different types of anemia that may be occurring on the blood chemistries that you're looking at. So now, once anemia has been identified, low red blood cell hemoglobin and hematocrit, then you want to ask why. And why has to do with production, destruction, or loss. And you can really determine the why of why a anemic tendency is taking place by looking at the MCV, MCH, MCHC, and RDW. I've put an asterisk next to MCV because of these three particular indices here, I've personally found more value from the MCV and looking at the size of the red blood cell, more so than the color of the red blood cell, which the MCH and the MCHC identify. But really, if all three of them are either low or high, then that's even more specific. But if MCV by itself are low or high, that seems to be fairly adequate in looking at why somebody may have an anemic tendency. So let's take a look at these particular indices, assuming that the red blood cell, hemoglobin, and hematocrit are all low in these individuals. Now what we're going to compare and contrast here is really iron deficiency anemia versus sideroblastic anemia versus chronic disease anemia, or anemia of chronic disease or chronic inflammation, as well as possible blood loss. So let's take a look at this. In this first one here, iron deficiency. Now remember, in heme synthesis, heme requires things like B6, zinc, and the very last step in order to make heme is the addition of an iron molecule. So in iron deficiency anemia, red blood cell, hemoglobin, hematocrit are all low because it's a production issue. The MCV, MCH, and MCHC will all be low. What this basically means is it has a small size, and that would make sense because if heme or hemoglobin is what fills up the majority or a third of a red blood cell, if hemoglobin synthesis is suffering due to heme synthesis, then you'll have a smaller than normal red blood cell, as indicated by a low MCV. A mean corpuscular volume, if it's low, means a smaller than normal red blood cell. A low MCH, MCHC basically mean that it's pale. It doesn't have enough hemoglobin in it, and it's not as red as one would like to see. Again, if hemoglobin synthesis production is deficient for some reason, there's a lack of hemoglobin in the cell, a lack of its ability to bind to oxygen, and therefore a more pale color. So low MCV, low MCH, low MCHC can indicate iron deficiency anemia. And lastly, in nutritional deficiency anemias, and this is very important, in nutritional deficiency anemias, the RDW will tend to be high. And this is because there's a production issue. Now, in an individual, if you remember with the RDW being the variance of red blood cell sizes, if somebody is deficient in iron, chances are, in the span of 120 days, as red blood cells are constantly being made every day, that maybe some days they actually have adequate iron intake. Maybe they go out and they have a large steak and some green leafy vegetables, and for those couple of days they have enough iron to actually make normal-sized red blood cells, but for the rest of the time they have small red blood cells. And this is why the RDW will tend to be high, because somebody has to be really overtly deficient in iron, for example, to have all of their red blood cells be smaller than normal and therefore maybe a normal RDW. So chances are in a standard iron deficiency anemia, you'd see low MCV, MCH, MCHC, and a high RDW. But how do you really know that it's iron? Talked about on another video, there's a marker called ferritin, and ferritin is a stored form of iron. Also on a standard blood chemistry, you have iron itself. In iron deficiency anemia, generally speaking, the iron will be low, and the ferritin, as the stored form of iron, will also be low. Now, if this particular pattern is present, as well as low iron, as well as low ferritin, there's a good chance that it's an iron deficiency anemia, and they probably need iron supplementally, as recommended by a licensed nutritionist or a licensed medical doctor, in order to help correct this iron deficiency anemia. Now, in terms of iron deficiency, it might be intake. Perhaps they're not consuming enough. It could be an absorption issue, for example. There's a number of different reasons, but a iron deficiency anemia will show low red blood cell, hemoglobin, hematocrit, MCV, MCH, MCHC, high RDW, low iron, and low ferritin. Now let's compare that to sideroblastic anemia. And this is confusing because sideroblastic anemia, if you notice, shows the exact same pattern. Low red blood cell, hemoglobin, hematocrit, low MCV, MCH, MCHC, and a high RDW. Now, sideroblastic anemia is anemia due to a vitamin B6 deficiency. So why does that show up as a microcytic hypochromic anemia that really looks exactly like iron deficiency anemia? And more importantly, how can you identify sideroblastic versus iron deficiency on a blood chemistry? Well, if vitamin B6 is one of the first steps involved in heme synthesis, and remember iron is one of the last steps, that iron in these individuals is not going to even be used, because earlier in the synthesis of heme, if it's not taking place, then iron has nowhere to go. It has nothing to do. It cannot bind on to heme because heme hadn't even been created, or the polyporphyrin ring hadn't even been created. So a difference in these particular panels, one of them, if you remember, iron deficiency anemia with no iron storage will show a low ferritin. On the other hand, Individuals with sideroblastic anemia will tend to have high iron and high ferritin because it's not actually being used in the production of heme. Heme is not being made higher up with a B6 deficiency, and therefore there's abundance of iron that has nowhere to go, high ferritin and high iron. So that's a real easy way to pick the difference between these. Another classic one, as discussed on a previous video, if you remember the quote-unquote liver enzymes AST and ALT, those are B6 dependent enzymes. If AST and ALT are low, below the lab range, what you may be looking at is a B6 deficiency. So, sideroblastic anemia may have a low red blood cell hemoglobin hematocrit, MCV, MCHC, MCV, MCH, MCHC, and a high RDW, as well as high iron, high ferritin, and a low AST or ALT. If that's the case, you may be looking at a sideroblastic anemia, which really is a vitamin B6 deficiency. Now, most commonly in our society today, this will be seen in chronic alcoholics because that will affect the absorption and metabolism of vitamin B6. But it's also possible that somebody lacks B6 in our diet today, and you may actually see this particular pattern. Now, let's compare these two excuse me, to anemia of chronic disease or anemia due to blood loss. Now, if you notice that the MCV, MCH, and MCHC, also the RDW in these, are normal. In the case of chronic disease, they may be low, they also may be normal. So let's talk about why. Now remember, red blood cell is the number of red blood cell. The RBCs is the count. How many red blood cells does this individual have? The hemoglobin is the content, the total content of hemoglobin in those red blood cells, and the hematocrit is the packed cell volume. If somebody's losing their blood, then those will all be low. They're losing the red blood cells, losing the hemoglobin, and the hematocrit will be low. But why is the MCV, MCH, MCHC, and RDW normal? This is because if it's truly a blood loss issue, it's not a production issue. And like I said, the RDW is great at catching a nutritional deficiency anemia because in nutritional deficiency anemias, the RDW will generally be high. In this case, the person is just simply losing their red blood cells. So it may be that they're actually being produced normally. They have normal amounts of iron, normal amounts of B12 and folic acid, and so the MCV, MCH, MCHC, and RDW are all normal. They're just simply losing their blood. Well, one thing that you may see in these individuals, however, over time, is ferritin, as we've talked about with some of these other patterns, may actually be low. And it may be low because in addition to losing their blood, they may be losing things like iron. So iron and ferritin may also be low in these individuals, eventually possibly causing what looks to be an iron deficiency anemia, but it may be an iron deficiency anemia due to blood loss. So these two can be very similar. If this is the particular pattern, it may be an early blood loss versus iron deficiency anemia due to intake or eventually due to blood loss, then this may be due to blood loss as well. And then the last one is anemia of chronic disease, also known as anemia of chronic inflammation. It is honestly very common today. In anemia of chronic disease, red blood cell hemoglobin and hematocrit may also all be low. The MCV, MCH, MCHC may be normal or low, and the RDW is likely to be normal. And the reason why, again, is this is not a nutritional deficiency anemia. That these could be normal because the red blood cells are being produced normally. There's adequate amounts of iron, B6, zinc, B12, folic acid, and they're being made perfectly. However, because of inflammation, the phospholipid membrane surrounding the red blood cells may be exposed to excessive oxidative stress. There's excessive damage to the red blood cells. They're destructing, and therefore the red blood cell hemoglobin and hematocrit may be low because they're lacking red blood cells, because they're being destroyed, because of chronic disease or inflammation, but that the cells themselves are actually relatively normal. Also, again, looking at this, ferritin in these individuals may be elevated. Ferritin, again, talked about in another video, is called an acute phase reactant. It's a protein that's made in the liver. That ferritin, if high, can indicate inflammation. Sometimes it can indicate excess iron. But in the case of chronic disease, if things like ferritin are high, then it may be as an inflammatory response. And a way to really know this is there's other inflammatory markers as well, like HDL, or high-density lipoprotein. If that's high, that can indicate inflammation. Things like CRP, which is another acute phase reactant, may also be high in these individuals. Therefore, looking at this more as an issue of anemia of chronic disease or inflammation as opposed to some of the other ones. So now let's take a look at if the MCV, MCH, and MCHC are actually high, what kind of deficiencies those can indicate. So let's talk about now if the MCH, MCHC, and the MCV are all elevated. In the case of a B12 or folic acid deficiency, if you remember from red blood cell synthesis within the red bone marrow, is one of the things it requires is called nuclear maturation. The nucleus of the early stem cells are actually fairly large, making a lot of amino acids, a lot of proteins, for example, the globin chains found in hemoglobin. Now, it's called nuclear maturation, and for nuclear maturation, which is the shrinking of the nucleus within the eventual red blood cell, requires both B12 and folic acid. If B12 and or folic acid are either deficient, the nucleus can't mature, and what you end up with is a larger than normal red blood cell. Now, to be sure, if the only one of these three are elevated as MCV, that's enough to really suggest that there's either a B12 and or folic acid deficiency. If MCH and MCHC are also elevated, then that just further helps determine that it is in fact a B12 or folic acid deficiency. Also, in most nutrient deficiency anemias, the RDW will tend to be high. Again, reason being is over the course of 120 days, red blood cells are constantly being produced. There may be times in this individual's diet where they do have adequate amount of B12 or folic acid, so they're making normal red blood cells, but for the remainder of the time they have larger than normal red blood cells, creating a wide variance in the size of the red blood cells and therefore a high RDW. Now, other things to help determine if this is a B12 or folic acid deficiency is that you can look at serum B12 levels, talked about in another video, serum folic acid levels, as well as homocysteine. Homocysteine is an amino acid protein that is found to be implicated in things like cardiovascular disease, maybe neurodegeneration, Alzheimer's, and some of these issues. And homocysteine, in order to get metabolized and converted into a less toxic compound to the body, requires both B12 and folic acid. So if you see somebody that has low red blood cell hemoglobin and hematocrit, as well as an elevated MCV and ideally MCH, MCHC, and RDW, as well as possibly having low serum B12, low folic acid, as well as high homocysteine, then what you're likely looking at is a combination of either a B12 and or folic acid deficiency. Now, we'll compare that to another fairly common type of anemia today called pernicious anemia. Pernicious anemia, if you notice, is essentially the same. However, I drew two arrows showing the MCV in somebody with pernicious anemia will generally be very high, fairly elevated outside of the laboratory reference range. And what pernicious anemia is also a B12 deficiency anemia. However, it's caused by something else entirely. That in the stomach, we have what are called parietal cells. And these parietal cells make a couple of different substances. One of them is hydrochloric acid, and the other one is called intrinsic factor. Now, intrinsic factor is a protein that binds onto vitamin B12 and transports it all the way down the entire length of our small intestine down to the last section or portion called the ileum. The majority of nutrients that we consume, vitamins and minerals, are all absorbed in the first portions of the small intestine, the duodenum and the jejunum. But in the 22 feet or yards of our small intestine, the last part is the ileum, and vitamin B12, once consumed, is bound to this intrinsic factor and taken down the length of our gastrointestinal tract down to what's called the distal ileum, the furthest portion of our small intestine, and then it's absorbed. Pernicious anemia is an autoimmune condition that attacks the production of intrinsic factor. So in these individuals, they can be consuming even vitamin B12 supplements. But without intrinsic factor, B12 cannot be absorbed. And so what you end up looking at is essentially a B12 deficient anemia, but it's not due to intake or absorption per se. It's actually an attack on the production of the protein that transports B12 and assists with absorption. Therefore, they have almost no absorption if intrinsic factor is not available. In terms of pernicious anemia, you'd see many of the same things. You'd see low serum B12, you might see high homocysteine, but then you also may see positive antibodies for either the parietal cells or intrinsic factor itself. And if those antibodies are positive, then what you're likely looking at is a pernicious anemia. And again, they should really talk to a licensed medical professional for the appropriate care. I want to wrap up the conversation we've had about the CBC, and I realize that this has been a longer than average video. But the CBC, in my opinion, is one of the most important parts of the blood chemistry when really trying to optimize health. That yes, we have cardiovascular risk markers, blood sugar markers, kidney, liver, and a variety of really great markers to tell us what's going on in the body. However, without oxygen, the cells of the body cannot make the optimal amount of ATP. And remember, ATP really is the energy for any given cell to do what that cell does. And if we are in the business of optimizing health, we want to optimize ATP production so every cell of the body can do what it does best. And looking at the CBC in somebody's ability to deliver oxygen to the cells of the body in the first place is fundamentally important, and just that really basic, fundamental way of getting oxygen to the cells of the body so that it can make ATP. Yes, we can improve blood sugar and decrease inflammation and all these great things by looking at other markers on a blood chemistry, but this is just absolutely fundamental. And this is sort of the art when it comes to blood chemistry. Now, I've talked about this before, but when looking at a CBC, it's not just about memorizing patterns. If you memorize patterns of what's high or what's low, iron deficiency, B12 deficiency, an individual, you'll get their blood chemistry at some point and it doesn't fit a pattern. And it's only if you understand what these markers are and the physiology behind it that you can critically evaluate what's going on and likely determine what's going on much better than most practitioners. Now, I say that because if you remember, dehydration will generally show as an elevation in the red blood cell hemoglobin and hematocrit, but most anemias will show as a decrease in the RBC hemoglobin and hematocrit. So it is very possible today that somebody is both dehydrated, showing an elevation in the red blood cell hemoglobin and hematocrit, as well as iron deficient, or let's just say B12 deficient, showing a decrease in the red blood cell hemoglobin and hematocrit. And if both of those are occurring simultaneously, then what you may see is normal red blood cell hemoglobin and hematocrit in that given individual, which is why it makes a lot of sense and is very helpful to look around at the rest of the blood chemistry. There are other dehydration markers like albumin, BUN, things like sodium and potassium. If those are elevated, for example, you may be looking at dehydration. Simultaneously, if somebody has low ferritin and low iron, they may also be iron deficient, despite the fact that they may be anemic, but it's not being picked up because they're also dehydrated simultaneously. Secondly, if you remember, iron deficiency anemia will tend to show low MCV, MCH, and MCHC. B12 folic acid deficiency anemia will tend to show high MCH or MCV, MCH, and MCHC. Now, if both of those are occurring in the same individual simultaneously, they're iron deficient and B12 folic acid deficient, then again, what you may see is normal MCV, MCH, and MCHC, when in fact, it's really a combination of being both iron deficient as well as B12 folic acid deficient. If you see those markers as normal, and an individual has, let's say, low iron and low ferritin, and over here may have high homocysteine, low B12 and serum folic acid, then you may be looking at both simultaneously, even though it's not technically showing up as either of them on a CBC. This is the art of looking at a CBC. This is what most practitioners don't actually critically evaluate, and is why individuals that are working with WellnessFX using this information have a greater chance and ability to actually figure out what's going on in these individuals. So let's finish up this video quickly by looking at platelets, and then we'll talk later about the CBC, the differential, and the white blood cells in a different video. The final discussion of this video is going to briefly talk about platelets. Now, what platelets really are, just so we're clear, is, let's just say this is a chunk of bone, and what we're really looking at is bone marrow. That within the bone marrow are these very large cells, as the name would imply, called megakaryocytes. And this is just so you have an understanding of what platelets actually are in the first place. Platelets are really just cell fragments. They don't contain a nucleus, they don't contain organelles. They only have a lifespan of around 8 to 10 days. And it's because what happens is these megakaryocytes that remain within our bone marrow, our red bone marrow, as the blood passes by through these what are called sinusoid capillaries, break off little pieces of these megakaryocytes, and what ends up going in the blood are these cell fragments. So this is why they only have a lifespan of about 8 to 10 days, is they're essentially, they were never really a cell in the first place, but rather just parts of a cell, these megakaryocytes, that are broken off and then end up in the bloodstream. Now, what's the role of platelets in the body? Platelets are considered to be granulated. There's a number of different granules that they contain in them, and generally speaking, they float around in the bloodstream non-activated. And their real role is anytime there's any kind of damage to the vasculature. For example, there's microvascular damage that's occurring all the time every day. And fortunately, we have these platelets that, in the exposure to some of the collagen and different components of the basement membrane of the endothelial layer of our blood vessels, when these platelets come into contact with some of this, they actually become activated. And now an activated platelet with its granules starts to release some of the contents of their granules that helps to activate the other platelets. And what they do is they essentially come in and form what's called a primary platelet plug. And that's essentially to stop bleeding. Now this can happen in a capillary or it can happen in a larger blood vessel. But in either case, if there's any damage to a blood vessel, this will help activate these otherwise inactive platelets. The granules start to release their different compounds, activating other platelets to come to the area to coagulate, if you will, accumulate and aggregate and form what's called a primary platelet plug. Now you can see that if somebody has an elevation of platelets on a blood chemistry, then that can be a risk for increased a risk for cardiovascular disease, for example. Is more platelets circulating around can indicate more potential damage, more potential for clotting, and then more potential for things like thrombus or embolus, and really causing a cardiovascular risk. So those are what platelets are and sort of what they do. So platelets, if elevated on a blood chemistry, the more common reasons for that today are things like inflammation, which again would make sense. Very often seen elevated in people with rheumatoid arthritis, for example, or even some cases in arthritis. So inflammation can increase platelet numbers on a blood chemistry. Another common one today is estrogenic hormone replacement therapy. So it could be oral contraceptives like birth control pill, or it could be hormone replacement therapy, estrogenic based, post-menopause, for example. In either of those cases, it's very common to see elevations in platelets, and it's due to estrogen and the estrogen effect on platelet production. Certain types of anemia can cause an increase, like iron deficiency anemia can cause an increase in platelet counts, for example, as well as certain liver conditions. Now, if platelets are ever low, the major issue from a health perspective would be possibly excess bleeding. Now, if it's low and it's due to some kind of pathological disease process, ideally the individual would already have known about this or should be referred to a doctor if the platelets are excessively low on a blood chemistry. Something I've personally found is low platelets aren't so much of a concern because it's one of the few markers on a blood chemistry that seems that maybe there's some spurious results sometimes, meaning that it's not necessarily an accurate result. And honestly, if platelets are low, follow up in a few months and see if platelets are still low. And if it is, then you may be looking at something like a B12 or folic acid deficiency causing low platelets or some other issue like that. So if platelets are high, there may be a risk for increased cardiovascular disease. The more common causes today are things like inflammation, as well as high estrogen levels, mostly from some kind of hormone replacement therapy. Some types of anemia, also some types of liver damage can cause that as well. Low platelets don't seem to be much of a risk except for excess bleeding if they're especially low, and causes of those things can be certain type of anemias like B12 or folic acid deficiency anemia. But really is probably not too much of an issue if it's not terribly low, and really should be followed up in a few months to see if that's actually an accurate result.